Hi there, how are you?
Hi there. Doing very
It's
well. It's
great to
very
see you
nice
as
to see you.
well. Still at the office. It's a long day.
You know, it's a
I know
long.
you
I
do.
start early, and but usually I'm done earlier than this, and I go home. I go to my study, and I start working on phase two. So we work hard, but there's nothing more important we could be doing. And I tell my staff very commonly how lucky they are to be doing this, to be doing something so important, something they're always going to feel good about.
Well,
And I think they believe me. I hope so. So let's see. Should we? People are still
yeah, they
joining us,
are.
aren't they? It looks like. I'm not an expert on Instagram webinars, so feel free to jump
Yeah,
in at any
absolutely.
point if I'm
Yeah,
off. And go ahead.
are you there? Oh
Oh, I
no, there
think
we
I've
are.
lost you.
We're
Ah,
back. We're
I'm still
back.
here.
Yeah, so as we're joining and as everyone's joining, Dr. Wood and I are going to be talking all things fertility related today, but we want to invite you all to post your questions. So if you've got questions for us, please make sure you post them. We will get to them in just a little bit. Okay? Awesome.
So I thought that what I do, kind of the unofficial title of this is the two detectives, because it's so important to know why. And in the last, let's see, yesterday and today, I've seen 5 new patients that had gone to other centers. And you want to know something? Not one of them knew why they hadn't succeeded. Not one of them knew why they were infertile. And you can't make good decisions about what sort of treatment you want to pursue unless you understand what the problem is. And so many fertility specialists say, oh, 30, 40, 50% of the time it's unexplained. But my experience, and I'd be interested in yours as well, is that truly unexplained infertility is relatively rare. When you look carefully, you can almost always find a reason for it. And once you find a reason for it, at least the first reason for it, then you know how to attack it. And that's really a key. If you don't know why you're doing what you're doing, you're just unlikely to do the right thing. And so you need to understand it, and then you need to explain it to the patient.
Yeah, I agree. I often get couples who come and they say it's unexplained, no one could find out why. And I always tell them, one of the things that I really believe is that there's no such thing as unexplained. I believe that we haven't asked the right question or run the right tests or looked in the right place to get answers. And oftentimes I do think that we pigeonhole ourselves a little bit because we're looking so narrowly at the situation that if we open up our perspective and take a step back, that we might find those causes, those reasons why it might be unexplained.
Right. Too often, we just look to treat. And based on our experience, based on some clues, we say, oh, well, you need this. Let's try that. We're going to give you supplements. We're going to, whatever. But you don't understand the reason. And especially, you and I deal with a lot of people, a lot of couples that have tried for a very long time. And they deserve a lot better than that. They deserve a thorough investigation. And so I think for today, what I'll do, if it's okay with you, is I'll tell you what we generally do. And I think that this works for 95 to 98% of patients. There's another 2 to 5% that really require very detailed investigations, but they're relatively rare. And so what I found is that when we do this, we usually find the reason, or a reason that we can go after. And the pregnancy rates are very high with that. And then I'd love to hear
Yeah,
what
that
you do.
sounds great. Yeah, that
How
sounds
does that
perfect.
sound?
Go for it. You start.
All right. So whenever I see a couple, the first thing I do is talk to the male. And why do I do that? Well, we know 50% of the time the male's involved. Also, the males deserve it. For so many years, it was the female that was investigated carefully. Probing questions were asked. It was the woman who had to kind of prove herself. And then at the end of the consultation, then you bring up the male. And it's absolutely unfair, and I don't believe in it. So unless someone comes in, a woman comes in and says, listen, I haven't had a period in 5 years. Okay, then we'll start with her. Under all normal circumstances, we're going to find out what's going on with the male. And it's been so interesting to me that a woman will come in and she has irregular periods. So there's an explanation. She's not ovulating well. And they'll tell me how she's taken cycle after cycle of Clomid or Letrozole, but it never succeeded. But they never checked the sperm. And then when you check the sperm, there's no sperm at all. So you have to find out what's going on with both partners before you decide what to do, except in the narrow circumstance where it's very clear what the problem is with the female. So that's what we do first. And then I ask the next question. And this is probably the largest category of infertility, which is not ovulating or not ovulating well, not ovulating consistently. And so there we ask the typical questions. Do you have a period every 28 days, for example? If they say yes, there's actually a reasonable chance, a high chance that they ovulate, but it's not at all certain. I've had many patients that ovulate very consistently every 28 days. They can set their watch by it, but when you actually test, we do a day 28 progesterone, you find out they're not ovulating. So you have to know that they're ovulating. In many cases, apparently they're ovulating, but the cycles are long or the cycles are short. And they describe other events that mean that the quality of ovulation was not good. And those two are very closely related. The things that give you ovulatory dysfunction also cause you not to ovulate. So it's kind of a blur in many cases. And in general, it's very easy to find out whether or not that's happening. That day 21 progesterone, actually it's a progesterone that's drawn 7 days before the expected period. By looking at that, it's very simple to tell if ovulation is not as it should be. So that's the first thing we do. If she's not ovulating or she's not ovulating well, there's a series of different tests that you do. You look at thyroid function, for example. You look at prolactin. One of the most common categories is polycystic ovary syndrome. And that's very easy to diagnose just by drawing blood. And then with the patients that I see, most of them are probably between 40 and 50. It's very commonly related to their ovarian reserve. And again, it's very simple just by drawing an FSH, an estradiol, and an AMH. It's very easy to determine if that's what the problem is. Once you know the problem, it's very simple to come up with a strategy. It may or may not work. Your first idea may or may not work. You may need to make additional changes to it, but at least you know the path to go. You know what you need to do. So that's the biggest category, for me at least. And then you have to ask yourself, does the fallopian tube pick the egg up? And I think many people don't understand how ovulation works. In my mind, it's kind of like the moon. And there's a rocket that takes off from somewhere on the moon. It can be on the bright side or the dark side. It could be almost anywhere. And that rocket takes off. And that tube needs to pick that rocket up. And it needs to take it in the tube. Well, how does it do that? Because here you have the moon and you have the tube right here. And the rocket is actually ejected from the other side. How can this tube actually pick it up? Well, the answer is that it's not as people imagine. People imagine that the tube is stuck to the ovary, and the ovary drops it in to the tube like a funnel. It turns out that the tube is constantly moving. It doesn't know where that rocket's gonna go, and it keeps moving and moving, and it's able to pick it up at a very high rate, and studies have shown that. Unless there's scarring around it, there are adhesions around it, or unless there's endometriosis. The woman has endometriosis. I think very few people understand why endometriosis is associated with infertility. But there's one study I love that I think explains it. And what they did is they took a tube out and they put it in a dish, and then they would stimulate the tube. and the tube would move, just as you would expect. And then they took fluid from the pelvis of a woman with endometriosis and they dumped it in this bath. And then the tube slowed down. It didn't move as it should. So in many cases, the problem with endometriosis is the egg never gets in the tube. I'll give you one more bit of evidence for that. A long time ago, when I first started, we did a procedure called GIFT, which is gamete intrafallopian transfer. And what we would do there is we would actually do the egg retrieval first. At the same time, someone would be prepping the sperm. And then we would take the sperm and the eggs and we'd stick it in a tube, in the catheter. And then we would take the eggs and sperm,
Right.
unfertilized, eggs and sperm, and we would put them in the tube. And the pregnancy rates for women with endometriosis were sky high. All you had to do was get the egg and the sperm in the tube. And we were running, this was, like in the mid 90s, we were running 70% pregnancy rates for women with endometriosis just by putting the sperm and eggs in the tube. And then the next question, of course, is the tube normal? So many women have tubes, and many times the tubes function fairly well at the end, but they're blocked because of a prior pelvic infection or ectopic pregnancy, a variety of different things. So you have to make sure that the tube is open and is normal in appearance. That sounds like a relatively simple thing to do, but it's not. And so the usual test that we order is a hysterosalpingogram. And many of the people that have joined us have been through that test. It's the most painful test that you could possibly go through. It's terrible. It's absolutely terrible. What happens is we put a catheter into the uterus, we blow up this balloon, then we pull it back so that the balloon is tight up against the cervix, and then the doctor slams some dye that can be seen by x-ray into the uterus. And when you do that, the sphincters at the opening of the tubes, they close up. They don't want to be hit like that. And then you get your diagnosis. Your tubes are blocked, but in fact, your tubes are not blocked. HSGs are wrong up to 60% of the time because of how they're done. So we don't do those very often here because I just don't believe the results. And too often you get results that will lead you down one path that's the wrong path for those patients. So we do something called FemView. And FemView is a fluid that has air bubbles in it. And we very slowly infuse it into the uterus. And you can actually see the fluid go into the uterus, and you can see that the fluid go out through the tubes and drop into the pelvis. And the whole time, you're doing it very, very gently. And when you do that, you get the right results. You don't get that kind of resistance. You don't get the closing sphincter that you get when you put it in there too quickly. So in general, that solves that issue. But I had someone today who had been going to a fertility center, I think it's been 5 years now. And in the 5 years, they had no idea if one of the tubes were blocked or not. And so they were doing intrauterine inseminations. And in some cases, the follicles were on the side that they weren't sure was open. And they say, hey, no problem, because of transmigration, which means that the egg is released from the ovary and then it swims across to the other side and goes in the other tube. Well, if that happens, a lot of bad things are associated with it, including ectopic pregnancies. But no one ever found out because whenever they did the HSG, they saw this blockage. So that's another key point to understand. And then you have to see, is the uterus normal? Are there fibroids there? Is there scarring there? And again, these things are generally pretty easy to tell just with an ultrasound. But in some cases, we need to do a hysteroscopy. And I love hysteroscopies. And I think patients do as well. They're painless procedures, nearly painless. You just take a scope, you pass it through the cervix, and you can see the entire inside of the uterus. You can see if there's a problem. You're not reading shadows. You're actually seeing what's there. And I love that. And then, of course, we look at the cervix and the vagina. I saw a patient maybe 6 weeks ago. She'd been trying to get pregnant for years. And I looked in with the ultrasound. In fact, she had two uteri.
And no one had,
Uteri. And no
no
one
one
had
had
diagnosed
known.
it in years.
Uh,
No one had seen it. No one knew it. And of course, that was the explanation for the problems that she was having. And that's basically the first round of tests that we do. Oh, I got to tell you one other thing. You've got to ask about
oh yeah.
intercourse. it's been so surprising to me that I will go through everything I just discussed and I'll get very good results. It sounds like it's unexplained. And then I say, how often do you have intercourse? And I remember one couple, they said, after we got married, we thought about it. And we realized that if we were going to have intercourse, it would make everything very complicated. So, in fact, they never had intercourse, which is absolutely fine for someone to decide. But that does play a role, doesn't it, in infertility? And so we were able to do IVF. So no intercourse was involved, nothing going through the cervix until the transfer was involved, and they were able to become pregnant immediately. But it's very important to understand that and to also look at the lubricants that they're using, that kind of thing. That can be an important factor as well. So that's my first round, and I'm looking forward to hearing yours.
Similar approach in terms of how we start to address things. When someone comes in, often one of the first things I do is just try to get an understanding for how regular or predictable their ovulation and menstruation are. Have they been tracking in some capacity? Do they know what their length of their cycle is? And I can't tell you how often I find when I ask these questions that women don't know how to answer the questions correctly, right? Which tells me they just didn't get the proper education at some point in time. Because I say, well, how long is your cycle? And invariably I get the answer as, well, I bleed for 5 days. Well, so I'm like, well, okay, so that's your bleed, but we want to know how long your cycle is. And so a cycle is, from day one to the next day one. And how many days is that? And that's typically 28 to 30 days. So that's the first thing we want to evaluate, is if someone is having a regular cycle or not. Are they ovulating at a predictable time? Do they even know when they're ovulating? And have they tracked those things? So that is one of the first things that we'll evaluate. And then on top of that, you ended your conversation or your point about intercourse. And so that's typically where we go next is, well, are you able and have you been timing intercourse appropriately, given the fact that you know where you're ovulating and how that's going? And often we'll hear a couple things. Well, sometimes we don't always make it happen at the right time. And then when I ask how regularly they have intercourse, often I hear not regularly enough. There was only one instance where I had a couple who said, oh, we have intercourse every day. I said, every day of your cycle? And she said, yeah, every day. And she was very proud of it, which was fantastic. But that's not the norm. That's not what we normally hear. We normally hear, oh, once a month, or when I know I'm ovulating, I'll make sure that we have intercourse. And so that's one of the things that I like to make sure that we coach and guide patients towards is, at least if you're going to be trying naturally, how can we time that a little bit more efficiently, right? So we want to know where we can start to try and how frequently we should be trying. And there's other variables involved in that, depending on how the sperm are doing. But those are the first two things that we're going to look at. And then I do. Yeah.
Let me make one point about that. One of the things that concerns couples is that they're not having intercourse enough. And they feel we're only doing it every other day. And they think if that's true, they're not going to get pregnant.
Right.
But there's actually a very interesting study that was done that looked at 2 times a week versus 3 times a week. And there really was very little difference between the two. And so you don't have to have intercourse every day, because that can have a very negative effect on the couple and on the experience of having intercourse. Because when you do that and you fail, it's like intercourse is a failure. And that can have a devastating effect on the relationship. So it's absolutely unnecessary.
Yeah, my goal with couples, whether you're in your ovulation week or not, is to have intercourse twice a week. I think one is that it keeps things consistent, and then 2, when it is your time during ovulation, you're gonna be able to catch that with that predictability, and also it just allows you to be intimate without having to always worry about if you're ovulating or not. So that's typically what I like to recommend. Yeah, at least twice a week. Yeah,
absolutely.
So then from there, before we ever look at labs, I want to get a good history. What else is going on? One of the things that I find is that we ignore a lot of the other ancillary health issues that are going on when we're looking at reproductive issues. And oftentimes rightly so, because our focus is on fertility and reproductive health. But I do find that those other health issues can impact things. And just this week, I had a woman who, when we did her evaluation, we found out that she had a lot of digestive issues that needed to be taken care of. So we put her on a protocol to really detox, because she had some bacteria and some overgrowth of yeast. And so we focused on that to begin with. And then the next phase, which I had just started to actually just finished preparing for her, which was really then going to be focused on her hormones and egg quality and so forth, we never even got to, because she got pregnant once we did all of that. And so, I say that because that's something that we often see, that when we're trying naturally, there's other influences impacting our reproductive health and hormones. And if we can also understand, the bigger picture of what else is going on, that our body, to function properly, really just needs to be healthy overall. And we can't ignore all the other pieces of what's going on in the body, just because we're trying to get pregnant. So we do look at that. We're going to look at adrenal function and stress response, and then, look at the rest of the picture in terms of their overall health, and start to prioritize whatever conditions and areas that need attention as part of the bigger picture. But of course, we have to look at hormones. So we also want to run those labs if they haven't been. Often we get patients who come in and they have many of the labs done, which is great. But typically we find that we're missing something. So we're going to look a little bit deeper at the thyroid if there isn't enough testing there or lab work there. Or we're going to look a little bit deeper at blood sugar, really depending on what's going on, because whether it's thyroid function or blood sugar, these are all different variables and systems that can absolutely impact our overall health and our reproductive function, specifically impacting our endocrine system. So we want to get the body functioning optimally, and that's where we start, is in those areas. Now, always, and you started here because you started with men, but I go there next and say, well, so you guys have been trying for X amount of time. Have we had a semen analysis? And at least 60% of the time, the answer is no. The other answer is, well, we haven't yet, but I've been trying to get him to do it. He just doesn't want to do it. So that is so important. We have to, it's 50% of the equation. And just like you said, 50% of the time we find that the sperm is the issue.
Particularly in the past, it's less now, but I've had a large variety of men that say, look, check her out. Check everything. Make sure everything's normal. If everything's fine, if she's not involved, okay, then I'll do a semen analysis. But It's just the wrong thing. I don't do that anymore. I don't allow that anymore. It's wrong. Women are the ones that carry the baby. Women are the ones that really give it all they have to have that baby. And it's unfair for a male to be unwilling to produce a specimen. There's no pain involved in that. There's a lot of pain involved in carrying a baby for 36 weeks and going through labor. And so that's what I explained to them. But in the past, it was really common. I'll do it only if there's no problem with her.
No, I mean, that is something that I agree with you. It's not something I'm okay with. I always push for that first and foremost, right off the bat. We want to make sure we have it. If they did one and it's years old, I want to repeat, where are we now? Because so much can change. I also often hear it's, oh, well, I have kids. I already have children. My sperm are fine. Well, they could have changed. A lot could have changed over time. So we still need to look at it.
The important point about that was a study that was done, I think it was done in Germany, where they looked at men that were having vasectomies. And they were having vasectomies because they were done. They had all the kids they could handle. No problems with fertility whatsoever. And when they checked those specimens, they were shocked that so many of them were so poor. So you cannot really look at a semen analysis and tell much about it without looking at the female as well. It's joint. It's like you need to get to a score of 100. And if the woman has a score of 95 and the guy has a score of 5, you're still okay. And so that's why you have to look at both. And you have to realize that in many, many cases of infertility, both people are involved to some extent. And so doing things that help both is the way to go. For example, a lot of places, they give the woman pills to take, and then they have intercourse. That does not work. One of the most important studies that's ever been done showed no improvement in pregnancy rate by doing that in women, in couples that had unexplained infertility. So we have to understand that both people are involved. And it's actually pretty rare that it's just one person. If she has blocked tubes, doesn't ovulate at all, there are a few examples like that. But you have to treat both members of the couple in order to succeed.
No, Dr. Wood, Elizabeth asked a really good question, because I'm sure a lot of people have this exact question as well. She says, how long is the process, and I'm assuming she's talking about IVF, how long is the process from beginning to end? Is there any risk factors in doing IVF?
Well, the whole process, the way we do it, is roughly, let's say, 6 weeks, because we do 4 weeks of pre-treatment that just involves taking a pill each day for the first 4 weeks, and then the actual IVF cycle begins. And the cycle, the stimulation part, is 10 days, and then 2 days later, the eggs come out. Are there any risk involved? Yeah, there are potential risk. I'm pleased I've been doing this for almost 30 years, and we've never had a complication. But whenever you take a needle, a sharp needle, and you pass it through tissue, you can always get bleeding, for example. You could theoretically get an infection. You know, a variety of things could happen, but the risk is extremely low, extremely low. In fact, particularly in places like Japan, that no anesthesia is used, and women come in every month, and they have another cycle. And each time they're just getting 1, maybe 2 eggs, and they do them. And I've seen some of these patients, and I say, how many cycles have you done? 22? You know, huge numbers. But the risk is really, really low. And I think that's why you have to be very careful who's doing your procedures. You want someone who's careful. And when you do a retrieval, you can do it like this, very gently, very carefully, or you can do what some people do, like bam, 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 all over the ovary. And when you do that, the risk is much higher, and the level of discomfort is also high. And one of the things that I've learned over the years is ways to minimize the discomfort. For example, in the last year, we've only had one patient that had pain after the procedure, after an egg retrieval. And it was so unusual, I went to talk to her. And then one of my staff said, oh, you know, the last time she did it at this place and that place, she had pain, and the previous time. So some people are just more sensitive to the discomfort. But if you're very careful how you do it and where you do it, the risk is extremely low.
It's all in the person who's doing it and their skill and experience. I 100% believe that, regardless of what, you know, whatever it is. Yeah.
Whatever it is.
So there's another good question here. Before I ask it, for everyone watching, if you've got some questions, now's your time. Go ahead and post them so Dr. Wood and I can answer those for you and help you along your way. Someone says it's hard jumping into the fertility world and picking a center to work with that fits your goals. I don't disagree. It is difficult, and I think, you know, my recommendation often is that we talk to a couple different, 2-3 different doctors or clinics, so that you can get an understanding for how they're different and who you connect with and why, what speaks to you, because it might not be the first one you go to. And I often hear this too. Someone says, oh, they tell me where they're going, for what clinic they're going to. And I said, well, how did you pick that clinic? Well, my friend who was successful there said that's where I should go. And I said, well, that's wonderful, but every clinic has successes and failures. So the question you need to ask her typically is, why do you like the clinic? And if they say, well, because I got pregnant, say, aside from that, what is it that makes you, like, what are the reasons behind it that make you tell me that I should go see that clinic or that doctor. There has to be more than just, I was successful there, so you should go there.
You know, I think what you said was 100% true. I've thought about this. Let's say that I suddenly forgot everything I knew about fertility and I moved to Cincinnati. Who would I see there? What fertility specialist? I have no idea. I don't even know how to tell. But I think what you suggested is probably the best way. You have to talk to them. There's some people that are extremely aggressive. I saw a 43-year-old woman today, and typical doses of medications that are used for a 43-year-old might be, let's say, a total of 250 units, something like that, of a medication. And they told me that they were using 675 units. They're using extremely high doses. These are things you can tell when you talk to them. How would you treat me? What medications would you use? What dose would you use? What's your philosophy on how to get the highest quality eggs? Now, there's one of my favorite studies was a study of 650,000 cycles. And what this study showed is the more medication you use, the lower the pregnancy rate. And yet we have people using massive doses of medications in this 43-year-old with 2 follicles. And obviously, nothing went well. She only got 1 egg, and the egg was fractured, didn't even get to the place that it could be fertilized. So I agree with you. I think you have to talk to them and make sure that they believe what you do. And I don't think there's any city where there's one person to go to. It may be that you talk to ABC and A is right for you, and your friend talks to ABC and B is right for them. So you need to have someone that has the same philosophy that you do, to find someone that matches you. I will tell you one thing. I think one of the most important things to find out is, will they listen to you? Because unfortunately, too many physicians feel like there's one way to do things, or 2 or 3. And so when a patient comes in, they say, let's put her on protocol 2, let's put her on protocol 3. You need to make sure they're going to listen to you and what you need and what you want, because this is really about you. It's not about the doctor. And that doctor needs to listen carefully to what you want and what you want to achieve, and then modify what she or he does in order to match what you want done. And I think that's so critical. And in so many cases, you'll tell them, look, I don't want to use high doses. I want to use low doses. I just want 1 baby. I don't want to take these massive doses I've heard about. Well, that's how you're going to get pregnant. If you do that, if you don't take those doses, you're not going to get pregnant. You don't want to hear that kind of thing. You want to make sure it's someone that will listen to you and tailor the treatment to you.
I think this point is really so important, because and I see this all the time, that just like that story you just mentioned of this 43-year-old who, maybe FSH was a little bit higher in her situation, and she didn't have a lot of follicles. And over and over and over again, I will see women who are overstimulated, and as a result, their body shuts down. It doesn't stimulate those follicles to grow more. It backs off. They retreat. It goes into a protective mechanism to just save itself. So it shuts down because it's overstimulated just for, these 2 follicles. And that's exactly why, because they're not customizing that protocol for that specific individual based on their history, follicle count, and lab values. And that's where we start to run into these things. So often when we hear this, someone says, oh, the doctor told me that, I didn't respond and my ovaries aren't working. And often my response is, well, I'm not so sure that's the case. I think it was often in that situation the protocol. It wasn't your body. And so we need to look at that in a different light. So asking that question, will you listen to me? Will you work with me, jointly to make this happen for me? I think that's a really important question to ask those providers that you're interviewing. Absolutely. Someone asked, Diana asked, and hi, Diana, thanks for joining us, by the way. She says, what are your thoughts on mini IVF? I know what Dr. Wood's going to say, but I'm going to let him chime in here.
I love mini IVF. I really do. And I didn't know IVF, mini IVF, when I started. No one was teaching it back then. It was something they do over there, not something that anyone would teach you. But I found that it's so valuable for so many women. Now, first I'll tell you that probably the leading proponent of mini IVF in the country did a study. They compared mini IVF to conventional IVF. And when he got the results, he published the results. And I have great respect for him for doing it, because what it said was there's no benefit to mini IVF. And I don't think there is any benefit to mini IVF for most women, other than those that simply want to use lower doses. The interesting thing about that study is that the results were the same, whether you did mini IVF or conventional IVF. But I can tell you this, if you only have 1, 2, 3, 4 follicles, there's absolutely no reason to do conventional IVF. You can use low doses, and when you use low doses, you get all the same number of eggs. You don't need to use high doses. So that's one thing. And
Yeah.
the other thing is, and this is a relatively recent thing that I learned, is that in the most difficult patients, in our patients that, let's say, are 43 to 48, if you do conventional IVF, you have no chance, almost no chance. But when you do what we call real mini IVF, which is very low doses of medication, almost no injections at all, when you do that, you can actually get normal eggs. So just last Friday, we had a patient that was 46 who finally got a normal blast. She had been trying. She's 46, and she'd been trying since she was 39, and she had never had a single normal blast. But by doing real mini IVF, she was able to get a normal blast, and I'm thrilled for her. She had been told so many times you cannot do it that she had come to believe it. But she did one last cycle before going to egg donation. So that's point one. Point two is, what is mini IVF? That's the problem. There's no definition of it. And so some people think mini IVF is taking 225 units or fewer per day. If you use that definition, that's really like conventional IVF, and you're gaining nothing by doing it. So you either have to go full in and do real mini IVF and get higher quality eggs and a greater chance of a normal embryo, or do conventional IVF. And so what we do is we either do low dose conventional, never high dose, low dose conventional, or we do real mini IVF with very low doses. And in my opinion, now based on hundreds of cycles, it's really the only way to have any kind of reasonable chance of getting normal embryos on a woman who's 43 or older.
Yeah.
It's a great question.
And I agree. I mean, I see that same sort of thing all the time with our couples when they're going to different clinics and on different protocols. And so I couldn't agree more with that. We have another question that says, what are the best lifestyle changes to incorporate to help with egg quality and fertility? I would say the first and foremost thing that we should be doing in this situation is, if you haven't already focused on cleaning up your diet and eating well, whole foods, less preservatives, less sugar, less junk food, less crap, really taking time to eat good quality food, and I think quality here is really important, then that has to be at the top of the list. Managing your stress levels has to be at the top of the list, and that looks different for all of us. For some of us, that means we need more rest, we need more sleep. For some of us, it might mean we need more movement, more exercise. For some of us, it might mean we need more meditation, or a combination of those things. So I do think pulling that together, but it has to be, this combination has to be the right thing for you based on what is reasonable for you. I always joke that, if someone told me that the only way that I can relax and take care of myself was to do yoga, it would never happen, because I don't like yoga, right? I'm not saying that yoga is bad. It's just not my thing. So for me to go and do something that's going to be relaxing and de-stressing, it can't be yoga. It would have to be something different. And so maybe for you it's yoga, or it's hiking, or whatever it might be, walking on the beach. You have to find those things. And it's really about setting that foundation with your lifestyle change. It's also about setting boundaries. You need time for yourself. You can't always be working. all the time. You need time for movement, time for rest. So it's really about finding balance in your life when it comes to managing lifestyle changes, really to support egg quality. But I also believe in customizing those things. So, you know, I don't know if when you ask these things, if you're asking about supplements and whatnot, but your diet could be different for all of you listening, and you could have similar issues going on because for each one of us, based on our lab work, we might have to do different things. We might have to adjust our diet differently based on our unique constitution versus somebody else. So those are, just because I'm saying like clean up your diet, I know I'm not giving specific instructions because that's going to be unique, or I believe it should be unique for each one of you listening. So
you brought up supplements, and I'm glad you brought that up. One of the supplements that both of us like is NMN. And, NMN has been shown in mice to reverse ovarian aging. And so I've been very interested to study exactly that. And so I was in shock when a study came out, and if the numbers are a little off, I apologize. I think they looked at 22 different brands of NMN on Amazon, and 17 of them either had no NMN or had greatly reduced doses of it. Yep. And that's terrible because some of my patients were taking those exact brands that had no activity. So we have restarted the study to find out what effect NMN has. But the reason I brought it up is I think it's very important that no matter what supplement you're going to take, you have to make sure that it's active. You have to make sure that the brand you're buying actually has what we recommend in it. And it's not easy to do because the number one brand on Amazon, it had a certificate of authenticity. It had a form indicating that the FDA had looked at it, which is suspicious. But the point is, they were faked. They were forged, and it's so difficult. So I think it's important to talk to Dr. Sklar, Dr. Sklar's office, or mine, and find out which ones you can believe in, because these supplements really work quite well in many cases. And I think that one of the reasons that many studies have not shown an effect is they haven't been using active supplement. And we know that's true. There's some studies out there that tell you what they use, and when you check, it wasn't active, and yet this study was published. So I hope that this kind of awareness will make supplements a more important part of this as we learn which ones actually work and which ones don't.
Quality is really important when we talk about supplements. I could say the same thing about vitamin D, by the way. They did a study, I think now 5 or 6 years ago, and they took, I think it was 100 of them off the shelf. And I think only 5 or 10% actually had in it what they said was in it. And so, quality, when you're spending all that money on supplements, we want to make sure that the quality that we're getting is what it says it is. And so that's really about finding a trusted source, finding, trusting, listening to someone like one of us who have looked at that, have investigated it, and have already done that hard work for you. So, yeah, that's an important point.
I noticed another question here about which brand of NMN is recommended. And if you contact our office, we'll send you a list of the ones that we have actually personally looked at to make sure that they're active. And so we'll be happy to send you that list. Just call the front desk.
Yeah, and on that note, as we're wrapping up, I'll also say that I have a free fertility guide that you all can download, and I do have the resources that I've vetted and looked at myself, and you can either direct message me for that, or you can just go to marksklar.com /fertility guide as well. But thank you so much, Dr. Wood, for having me. I really appreciate it, and thanks everyone for asking those wonderful questions and joining us today.
Very nice to talk with you. I always learn from you.
And I from you. I appreciate it. Bye, everyone. Thanks so much for joining us.